It's September 6th, 2024. This is the Rheum Now podcast. Hi, I'm Dr. Jack Cush, executive editor with rheumnow.com. This week on the podcast, I got a few topics and presentations that are all about the fingers. You know, color of fingers, things that happen to fingers, and fingers are really important to us rheumatologists. I think that's what's great about rheumatology, because while your patient evaluations may begin with a handshake, I know that my patient assessments begin with reaching for their hand and holding their hand and examining their hand. Sometimes I'm taking in their hand while I'm talking to their face, and I'm feeling temperature, color, the smoothness of the skin or not. And there's a lot can be told. I mean, the way to the diagnosis is often through the hands. So I like that it begins with the hands, and I like that I'm highlighting fingers in this podcast. Of course, it all ends with what we do and what we prescribe, and we're going to cover that today as well. I don't know if you've noticed some of these reports that have appeared in roughly the last few years about the associations between GERD and H. pylori and the etiology of rheumatoid arthritis. I put those up this week as tweets back to back. I think it appears today on social media. And it's curious. So one comes from Nature, and it's a sort of an explanation paper about how the gram-negative bacteria H. pylori may actually either exacerbate rheumatoid arthritis, which it's been reported to do, or may even be involved in the pathogenesis. And the idea here is that infection of gastric epithelial cells will lead to an upregulated expression of PAD4, an enzyme very important in rheumatoid arthritis pathogenesis and what's going on in the synovium. And this increased PAD4 activity can lead to increased citrullization, which will lead to ACPA, which may have a role, obviously, in the pathogenesis of the disease. So is this real? Is this something that we should pay attention to? Should we be treating everyone for H. pylori? I know I look for it from time to time. So another study I found from, I think a year back, 2023, a study of almost 5,000 patients who are undergoing, and these are not arthritis patients, these are people undergoing upper endoscopy. And of the 5,000, about 2,300 had an H. pylori infection, and about less than half of those had what's called a long-lasting H. pylori infection, 22%. Of those people, they had they noticed overall a 6% incidence of atherosclerotic cardiovascular disease and a 4.3% incidence of rheumatoid arthritis. Okay, none of this sounds too surprising. These people are average age of around 50 years of age, but it turns out that having this long-lasting H. pylori infection increased the odds of having cardiovascular disease with a hazard ratio of 1.57, 57% increase, and increased the risk of developing RA or having associated RA with a 2.6-fold increased risk, so a hazard ratio 2.63. If you had RA and you had a long-lasting H. pylori infection, you had an 8-fold higher odds of cardiovascular disease. Obviously, this association between RA, inflammation, cardiovascular disease is not surprising you. What's surprising here is what's the deal with H. pylori and GERD? Is that part of the mucosal hypothesis upon which maybe rheumatoid inflammation may start? I think this is interesting. I think we'll have to pay attention to this. A quick report this week about better management of problematic Behcets and how to prevent uveitis. This is an open-label head-to-head trial of adalimumab versus cyclosporin. It just basically showed adalimumab was better than cyclosporin in preventing relapses in patients who already had severe Behcets. Do I want to spend a lot of time on this? No. The point I want to make is I'm not an expert on uveitis prevention or uveitis management in Behcets. I may even not be an expert at Behcets. How do you manage these cases? Well, staying up on the literature is one thing. Me, I pick up the phone. I call Yusuf Yaziki, or I call the rheumatologists who are great at eye disease and ask for advice because they know this kind of data. I think we encounter these fringe, difficult cases all the time, and I don't think it's a problem for you to reach out to me or anyone else you want to help to get some input on these difficult cases, because sometimes you just can't do it alone. RA and MACE, a well-known association. This particular report of a cohort of over 4,000 patients followed for, looks like maybe 6 years or so. They had 362 cardiovascular events, major adverse cardiovascular events called MACE. Turns out there was a good association between rheumatoid arthritis and activity and inflammation markers and MACE risk, but only in people who were not taking biologic DMARDs. Guess what? When you look at those who are taking biologic DMARDs, the risk association went away, which says that more effective treatment can help to abolish that risk. Again, sometimes the question at hand is, why should I use an expensive biologic? Well, this could be one reason, but I don't think it's the only way you get to disease control and the abrogation of the SED rate and CRP that seems to be high. I think it might get you there if in combination, but whatever it takes to get there, inflammation and inflammatory markers need to be nullified. A claims analysis of a fairly large cohort of GI patients with IBD and or RA found that the overall risk of an invasive fungal infection, IFI, was about 0.5%. That would be about 5 per 1,000. Turns out that the actual risk, I think was, I didn't write it down here. I want to say it was 3.3 per 1,000 patient years for IBD and about the same, 2.8, or maybe it was a little bit higher. Maybe it was 4 for RA. I've often said that these fungal infections, opportunistic infections, rare infections, it's a 1 in 1,000 risk. And again, this is the risk of people who are taking a TNF inhibitor. So that's really what the point I want to make is that TNF inhibitors, the risk of serious infections is what, 2 to 9 per 100 in a year. But rare infections, like the fungal infections, are roughly 1 in 1,000, a few in 1,000 events. But you got to think about them when they're on these drugs because they're so rare, they often go undiagnosed. Histoplasmosis in this cohort was the most common. The IBD risk was 3.3, the RA risk was 2.8 per 1,000 patient years. Okay. Dactylitis is seen in 50% of patients with psoriatic arthritis. This particular report says it's associated with a more severe phenotype and more severe disease, and it may be the initial presenting feature of the disease. I added the editorial comment that while dactylitis is common, we don't really yet have a drug that really works great for dactylitis. Actually, all the drugs we would use for PSA and SPA are all pretty good. TNF inhibitors, IL-17 inhibitors, the 23s, even apremilast, they all work pretty well in dactylitis. But none stands out. Ustekinumab is in that group, but none stand out as the clear-cut winner. I would like to see a clear-cut winner because in some patients, that's the main thing I have to manage. Speaking of fingers, I found on the website Radiopaeia, that's spelt the British way, RADIOPAEIA.com or .org. It's a radiology website. It gives you great radiology examples with small case reports. And I came across one of acroosteolysis in a patient with scleroderma and renal failure. The patient had bilateral hand pain. They did an x-ray, and you can see the resorption of the distal tufts of the distal phalanx in a few fingers. They called it vanishing fingers. And there are other causes of acroosteolysis besides scleroderma, psoriatic arthritis, hypertrophic osteoarthropathy of the chronic kind, several skeletal dysplasias, frostbite, parathyroidism, hyperparathyroidism, and there are a bunch of rare genetic disorders that can cause this. But again, I think often this acroosteolysis is something you're going to get in a radiology report from the radiologist, and now you have to think of the differential diagnosis. There was a nice report in Lancet Rheumatology this week about Raynaud's phenomenon and how and when it occurs. And the point that was the standout point of this particular report was that it obviously is most common with very cold temperatures. But guess what? it also happens with very warm temperatures. So they give you a bunch of temperature ranges and frequency rates. And the bottom line is that the hotter it gets during the summertime, the more you get reports of Raynaud's, presumably because of the hotter it is, the more air conditioning the patient is exposed to. So this was based on Q3 month assessments of over 2,200 Raynaud's patients. They were mostly women, mostly white, etc. But this is a report in Lancet Rheumatology. Another nice report came from JAMA Network Open, I think it was, about Scleroderma findings in patients with skin of color. So what happens when you have Scleroderma and you're African American, Hispanic, Asian, whatever, not white skin. White skin, obviously, all the skin lesions of Scleroderma show up really, really well. Well, in this particular review, with a fairly good-sized cohort, Raynaud's was common in all skin color groups. But in the people with skin of color, there were fewer of the hallmark findings that we rely on, and that would include telangiectasias, calcinosis, and digital swelling. Patients with skin of color were more likely to have more severe pulmonary disease, more atypical skin findings, and increased mortalities, suggesting that patients with skin of color and autoimmune disease can be a challenge. And thank goodness you're experienced and expert in managing and diagnosing these patients. Further reports on lupus this week. There are a number of them. A retrospective observational study in Frontiers looked at 96 patients with lupus who had maintenance therapy with either hydroxychloroquine or belimumab, and the takeaway point on this was that flare rates when you're on either belimumab or hydroxychloroquine were roughly the same. The flare rate on hydroxychloroquine, 18%. A little over 8% with belimumab, that no significant difference in flare rates or in damage done or in sleet eye or prednisone or adverse events. And the point by the authors was that belimumab makes a good maintenance option when you can't use hydroxychloroquine. I think the point is that I'm going to use hydroxychloroquine in everyone as much as I can, and then maybe I fall back onto belimumab, because obviously hydroxychloroquine works very, very well. Speaking of hydroxychloroquine, there was another report. Actually, this one was from JAMA Network Open. The other one, you're going to have to look up the citation. This is about a French population study that showed that sustained use of hydroxychloroquine was associated with significant reductions in future cardiovascular outcomes. We know that. Everybody with lupus should be on chronic vitamin H or P, hydroxychloroquine or Plaquenil, and it's because of the many, many benefits, one of which is reduced future cardiovascular risk. Also reduced insulin resistance, better diabetes control, antithrombotic effects, I can go on and on, better pregnancy outcomes, etc. Anyway, this French population study of 52,000 lupus patients, mean age 44, mostly 80-something% women, followed 9 years, that there were 1,981 cardiovascular outcomes, myocardial infarction, stroke, thromboembolic events. And they matched that basically 1 to 15, it looks like, with match controls without lupus. And basically the hydroxychloroquine exposure. So the match controls must have been other lupus patients, not hydroxychloroquine. That the composite cardiovascular endpoint was 37% lower, odds ratio of 0.63. Also, and the composite was MI, CVA, and thromboembolic events. And the reductions on those were, again, about 30-40% each. And all that was significant. So, again, I put this up because I think it is a major point in rheumatology that about the less than obvious benefits of chronic hydroxychloroquine use. The other interesting study this week that I missed, actually, from a few months ago, I think it was published in June or July, from Karen Kostenbatter, who was looking at the Nurses' Health Study, as you know, a prospective study of over 200,000 nurses followed for a bazillion years. And in that cohort, there were 212 patients with incident lupus. They found a significant association between the intake of ultra-processed foods, and the developing lupus. So, and basically a greater than 50% increased risk in incident SLE, and a doubling of the risk for positive double-stranded DNA titers. In this cohort study, they showed that sugar drinks and artificially sweetened drinks was also associated with a higher risk of lupus, about a 45% higher risk. Again, this goes down the path that we've been talking about lately about those, ubiquitous factors that are probably unhealthy lifestyles or unhealthy exposures that do add to the development of autoimmune disease, especially in some susceptible people. What the susceptibility here was, I don't think it was being a nurse, by the way, was something beyond the diet. So lastly, a really cool study in New England Journal from yesterday was a letter to the editor about achieving CAR T-cell-like effects with a new bispecific monoclonal antibody called teclistamab. Teclistamab, the trade name is Tecvayli, Tecvayli. It's a drug that's FDA approved for use in multiple myeloma. This is a single case report, but I think the fact it was in New England Journal because the claims that were made here make it worth bringing to your attention. The patient was a 23-year-old in Berlin who had very severe lupus that was refractory to multiple therapies. And while they probably would have liked to have given CAR T-cell therapy, they chose this one. It's a bispecific agent that binds to CD3 and also to BCMA, a B-cell maturation antigen, which is another way of targeting B cells. And they notice rapid and complete CAR T-cell-like effects, all the autoantibodies going away, all the B cells dropping, all the skin and joint and systemic symptoms, boom, gone. Patient was in total remission at week 16. So why is this different than CAR T-cell? Well, number one, it's a lot cheaper. Number two, there's no need for preconditioning. Number three, we don't know that it's going to last as long as CAR T-cell. Dr. Schett's got some incredible data that says that a few years out after CAR T-cell, those patients are not yet taking any therapy and their lupus is in remission. They only give you 16-week endpoints. The drug is given as a subcutaneous injection, 3 injections in the first week and another injection on week 2 and week 5, something like that, sort of an odd regimen. But they adhere to the myeloma regimen, and I think I'd like to see clinical trials in this in the future. I think it's kind of cool. So our last report is from Dr. Smolin. It appears, I think, in rheumatology. Pardon me if it was ARD, but I think it was in rheumatology, and it's about a sub-analysis of the Accelerate study, which, as you know, was published a number of years ago, a head-to-head trial of certolizumab versus adalimumab in RA patients. As you know, the drugs were equal in their effects. In this sub-analysis, and the Accelerate was a 2-year study. In this sub-analysis, Dr. Smolin had the idea, and his investigators as well, had the idea that certolizumab doesn't have an FC portion, and that adalimumab does have an FC portion. What about patients with really high titer rheumatoid factor? Might you get binding of rheumatoid factor to FC receptors on the adalimumab, thereby making its effects different than that of certolizumab, which doesn't have an FC receptor? So that's exactly what happened in this sub-analysis. 453 patients treated with certolizumab versus 454 with adalimumab. They compared those in quartiles, the fourth quartile being high titer rheumatoid factor greater than 204 international units per ml, and the first 3 tertiles were rheumatoid factor positive, but in lower amounts. What they found was that adalimumab concentrations were lower in patients with the highest titer of rheumatoid factor, but certolizumab patients had no change in their drug levels, even in the high titer rheumatoid factor group. So this was not just drug concentration, there were clinical benefits both to -28 CRP levels, -28 CRP low disease activity state, and CDI, low disease activity state, meaning you got better responses with certolizumab in the high titer rheumatoid factor group, and you had somewhat less responses. Now, the overall study, as you know, not looking at rheumatoid factor, ACPA, anything else, showed no difference in the response between adalimumab or certolizumab. But if you look at the rheumatoid factor, maybe there's something there. And there have been other reports that mirror this kind of research in small cohort analyses. The other thing about this particular sub-analysis of the Exhilarate study shows that it didn't matter if you had high titer ACPA or not, right? Only rheumatoid factor is going to bind to FC. So, anywho, this was kind of a cool thing, and I think I'd like to see more studies, and maybe if this were true and consistent, it might color whether I would use certolizumab versus adalimumab in the future. I want to remind you, today is the 6th of September. Today begins the Advanced Rheumatology and Therapeutics Symposium run by Orrin Traum and Alvin Wells. So if you're in Chicago, the JW Marriott's got a 2 or 3 day meeting that is a powerhouse meeting that I think you really should attend. If you look at the faculty on this, Dr. Schett's going to be there. The organizers of this is Traum and Wells and Michael Putman and Alexa Mira and whatnot. The faculty is John Botson, Eric Campbell, Anisha Dua, Philip Meese, Amanda Mixon, Jeff Peterson. Again, a lot of great faculty for this meeting. If you're in Chicago, check it out. It's at the JW Marriott. That's it for this week on the podcast. Go to the website to check out these citations and more. We'll be talking to you next week on the podcast. Take care.